Good afternoon, everyone. Today we will be discussing about intravenous fluids. I am Dr. Sanket Mantri, and moderator for this topic is Dr. Sushit sir, faculty anesthesiology. We will be discussing this topic under following headings like introduction, basic principles of fluid therapy. In that we will be discussing what are the indications of IV fluid therapy, what are the advantages, disadvantages, contraindications and complications. Then we'll see what are the types of intravenous fluids. Then we'll see the pharmacological and clinical basis of intravenous fluids, and then methods of delivering IV fluids. So, as we all know, and we have studied in pharmacology that the principal oral route is always preferred over IV. But intravenous fluids therapy has a great importance in various clinical problems. Parenteral fluid therapy usually involves the intravenous administration of the crystalloid, colloids, and blood products. We will see what are the crystalloids, what are the colloids, and all these things in further slides. As in history, in 1492, first attempted blood transfusion was done, but it went unsuccessful. In 1830, first successful blood transfusion was done. The first use of was saline for IV resuscitation is usually attributed to William in 1831 on cholera patient. In 1834, first IV use of albumin was done. In 1861, Thomas Grams is investigated and classified the substance as a crystalloid and colloid on the basis of the transmission of the fluid in around the semi-permeable membrane. In 1876, Ringer's solution is introduced. In 1975, FDA approval of total parental nutrition was done or approved. In basic principle of fluid therapy, as we all know, there are various fluids are there, but fluid therapy is widely used for restoration of the fluids and electrolyzed as a drug carrier or for nutrition. The most common indication for basic fluid therapy is the condition when oral intake is not possible, like in coma or in surgery, in severe vomiting and diarrhea, in moderate to severe dehydration and shock, where urgent and rapid fluid replacement is needed, in hypoglycemia, where we give 25% dextrose as it is life-saving, or as a vehicle for various IV medications. It is also indicated in total parental nutrition or treatment of critical problems like shock, anaphylaxis, severe asthma, cardiac arrest, or for diuresis or in poisoning. We use IV intravenous fluids. What are the advantages? First advantage is accurate and controlled and predictable way of administration. Second is immediate response due to direct infusion in intravascular compartment. Third is prompt correction of serious fluid and electrolyte disturbance in serious fluid electrolyte disturbances. What are the disadvantages? In that it is more expensive and needs strict asepsis. Possible only in hospitalized patient under the skilled supervision. Improper selection of type of fluid used can lead to serious problem. Improper volume and rate of infusion of fluid can lead to life-threatening complications. An improper technique of administration is also hazardous. In contraindication, IV fluid should be avoided if the patient is able to take oral fluids, and to preferable to IV fluid in patient preferable to avoid IV fluid in patients with CCF, that is congestive cardiac failure or volume overload. In complications, we will be dividing complications into three main headings. First is local complications, second systemic, and third others. In locals, as we know, hematoma or infiltration or infusion phlebitis may occur. In systemic, circulation overload with a rapid and large volume of infusion, especially in patients with cardiac problems, may occur. And in others, fluid contamination or fungus in IV fluids, or mixing of incompatible drug may occur, or improper technique of infusion, or IV catheter related problem, or some human error related problem also occur. So these all are the complications of intravenous fluids. Next, we will be going into basics, some basics as we all know, but just we will touch these concepts. Osmoles, as you know, osmoles is unit of concentration of osmotically active particles. Osmolality is osmotic active solute per volume of solution, that is milliosmol per liter. Osmolarity is osmol per kg, and it is very important that plasma osmolarity is 290 milliosmol per kg. It is very important MCQ also. Tonicity, relative osmotic tonicity is relative osmotic activity. Now we will be moving towards the type of intravenous fluids. There are three main types of intravenous fluids: maintenance fluid, replacement fluid, and special fluids. In maintenance fluid, first it replaces the fluid lost from lung, skin, urine, and feces. These losses are poor in salt, so maintenance fluid should be hypotonic to plasma sodium. The maintenance fluids are 5% dextrose with 0.45% NaCl solution, that is dextrose with half isotonic saline. Next is replacement fluid, formulated to correct body fluid deficit caused by losses such as gastric drainage, vomiting, diarrhea, fistula, drains, intestinal edema, oozing from trauma, infection and burns, etc. The replacement fluids are isotonic saline, DNS, RL, isolite M, isolite P or isolite G. Special fluids are the fluids used for special indications such as hypoglycemia, hypokalemia, metabolic acidosis. 25% dextrose, injection soda bicar or potassium chloride are the special fluids. The main two classes of intravenous fluids are colloid and crystalloids. Now we'll see what are the advantage of colloids and what are the advantage of crystalloids, that is advantage and disadvantage of colloids and crystalloids. So colloids are smaller infused volume, prolonged increase in plasma volume, and less peripheral edema occur with colloid. But disadvantages are greatest cost, coagulopathy. It is mostly commonly seen with dextran. Then pulmonary edema, decreased in GFR, osmotic diuresis, greater duration of excessive volume expansion. And crystalloid, what are the advantage of crystalloids are lowest cost, greater urinary flow, interstitial fluid replacement. Disadvantages are transient increase in intravascular volume, transient hemodynamic improvement, or peripheral edema or pulmonary edema may occur. So we will be moving towards the pharmacological and clinical basis of IV fluids. As we know, for proper selection of IV fluids, we need to know what are the composition of that fluid, what is the pharmacological basis of that fluid, what are the important indications, what are the important contraindications of that fluid. So one by one, we will be discussing all the important intravenous fluids which we are using in day-to-day life. First, we will see the ringer lactate. Composition. In composition, 1 liter of fluid supplies sodium, that is 130 milliequivalent, potassium, that is 4 milliequivalent, chloride 109 milliequivalent, calcium 3 milliequivalent, and bicarbonate 28 milliequivalent. And each 100 ml contain sodium lactate 320 mg, sodium chloride 600 mg, potassium chloride 40 mg, and calcium chloride 27 mg. What are the physiological basis of ringer lactate? It is having high sodium, so expands intravascular volume. Most physiological fluid. It is the most physiological fluid. As the ringer lactate provides bicarbonate, so it is useful in correction of metabolic acidosis. Indications. It is used in correction of severe hypovolemia, for replacing fluid in post-operative patients. or in patients with burns, patients with fractures like long bone fractures, femur fracture or tibia fracture. In that case, hypovolum, uh, hypovolumic shock, chances of hypovolumic shock is more. So RL is very useful. In peritoneal irrigation, RL is also very useful. Diarrhea induced hypovolemia, in diabetic ketoacidosis, for maintaining normal extracellular fluid, that is ECF volume, and electrolyte balance during and after the surgery. RL is also very important. Now, what are the contraindications of ringer lactate? It in liver diseases or in severe CHF, Addison's disease, severe metabolic acidosis, in vomiting or continuous nasogastric aspiration, along with blood transfusion. The calcium in the RL binds with certain drugs, that is amphotericin, thiopental, penicillin, or doxycycline. So we can't use RL there. Next is DNS, that is 5% dextrose with 0.9% NaCl solution. The composition, that is 1 liter of fluid, contain glucose 50 milligram, chloride 150 milliequivalent, and sodium 154 chloride 154 milliequivalent and sodium 154 milliequivalent. Each 100 ml contain glucose 5 gram and sodium chloride 0.9 gram. Now, pharmacological basis. This fluid has advantage of both 5% dextrose, which provide energy, and isotonic saline to provide salt. Like 0.9% isotonic saline, it is rapidly correct NaCl deficit of ECF. Unlike the D5, DNS is not hypotonic, hence it is compatible with blood transfusion. What are the indications? Correction of salt depletion and hypovolemia with supply of energy. Correction of vomiting and nasogastric aspiration, induced alkalosis and hypochloremic along with supplies of calories. Fluid compatible with DNS, that is compatible with blood transfusion. Contraindication, it may cause anasarca, that is edema over whole body. Hypovolemic shock, severe shock where rapid correction is required. Now we'll see isotonic saline, that is 0.9% NaCl, that is normal saline. Composition, 1 liter of fluid contain sodium 154 milliequivalent and chloride 154 milliequivalent. So each 100 ml contain 0.9 gram of NaCl. Pharmacological basis. Sodium chloride is present chiefly in extracellular fluid, maintaining osmolarity of ECF. So isotonic saline is used to prove the major extracellular electrolyte. Indications. Water and salt depletion, as in diarrhea, vomiting, excessive diuresis or perspiration. Hypovolemic shock. Treatment of alkalosis, or in severe salt depletion or hyponatremia where rapid correction of sodium is necessary. The miscellaneous indications are initial fluid therapy in diabetic ketoacidosis. It is also used in hypercalcemia. It is used in hypercalcemia or fluid challenge in pre-renal ARF, that is acute renal failure. Irrigation for washing for washing for washing body fluids. Now, contraindication. Cautious use or avoid in hypertensive or preeclamptic patients and in patients with edema due to CCF or renal disease or cirrhosis. Careful administration to very young or elderly patients, and dehydration in severe hypokalemia. Now we'll see the 5% dextrose. Composition is 1 liter of fluid contain glucose 50 grams. Pharmacological basis, 5% dextrose correct dehydration and supplies energy. After the consumption of glucose, remaining water is distributed in all the compartments of the body proportionately. Therefore, best agent for correction of intracellular dehydration is 5% dextrose. Indications. Widely used fluid for prevention and treatment of dehydration due to inadequate water intake and excessive water loss. It is the cheapest fluid to provide adequate calorie to the body. For the pre and post operative fluid replacement, we can use 5% dextrose. For IV administration of various drugs, For the treatment and prevention of ketosis in starvation, diarrhea, vomiting, and high-grade fever, we use 5% dextrose. Protect liver against toxic substances and correction of water due to pure water loss. Contraindications: cerebral edema, neurosurgical procedures, acute ischemic stroke, sorry, hypovolemic shock, hyponatremia and water intoxication, blood transfusion, and uncontrolled diabetes mellitus and severe hyperglycemia are the contraindications. Now we'll see the isolate G. It is used in vomiting and continuous nasogastric aspiration to replace the loss of gastric juices. It is used in treatment of metabolic alkalosis due to excessive administration of sodium bicarbonate or aggressive diuretic therapy. Isolate M. It is indicated in parenteral fluid therapy. It is ideal maintenance fluid. It is used to correct hypokalemia secondary to diarrhea, bilious vomiting, and prolonged infusion of potassium-free IV fluids and ulcerative colitis. Isolate P. Chiefly used in maintenance fluid in infants and children to provide daily water and electrolytes. Excessive fluid loss or inability to concentrate urine, that is diabetes insipidus. In this condition, we can use isolate P. Contraindications are hyponatremia, renal failure, and hypovolemic shock. Isolate E. It is indicated in diarrhea and metabolic acidosis. It is used in maintenance of ECF volume preoperatively. Now we'll see what are the colloid solutions. Colloid are the large molecules, so when infused into intravascular space, they are retained within the vascular system, unlike crystalloids. So colloids are more effective than the crystalloids as plasma volume expands. So colloids are near about 3 times more potent than crystalloid for increasing vascular volume and supporting cardiac output. So characteristic of IV colloid fluid per 100 ml of infusion. So there are various types of colloids like 5% albumin, 25% albumin, 6% hetastarch, 10% pentastarch, 10% dextran, 6% dextran 40 or 70. So effective plasma volume expansion and duration of expansion is very important about all these colloids. Now we'll see one by one, we'll see the colloids. First is albumin. Albumin is physiological plasma protein. The chief function of albumin is to maintain oncotic pressure. Now we'll see what are the indications. First, plasma volume expansion. Correction of hypoproteinemia. As an exchange fluid, in the therapeutic plasmapheresis, albumin is used as an exchange fluid to replace or remove the plasma. Precaution. So what are the precautions we have to take during the infusion of albumin? So fast infusion will rapidly increase the circulatory volume with resultant vascular overload and pulmonary edema. Given with caution to patients with low cardiac reserve and cardiac insufficiency. It is contraindicated in severe anemia and cardiac failure. Now we see Hetastarch, that is hydroxyethyl starch. Available in 6% solution of isotonic saline. Advantages. It is non-antigenic, fewer antigenic properties are compared to dextran. Hetastarch does not interfere with blood grouping or cross-matching. Hetastarch less expensive than albumin and expands plasma volume for a longer period and effect lasts for about 24 hours. Disadvantages: increase in serum amylase concentration. So serum amylase cannot be used as a tool for diagnosis of pancreatitis near about after 3 to 5 days of infusion. Like other colloid, it has a no oxygen carrying capacity. So one should not allow hematocrit to fall below 30% after an infusion. What are the indications? Safer and effective plasma expander and to correct hypovolemia and shock. Now we see the dextran. Dextran are the glucose polymers produced by bacteria, that is leucohosto, incubated in a sucrose medium. Available in two forms of molecular weight, dextran 70 and dextran 40, that is 70 molecular weight is 70,000 and dextran 40 molecular weight 40,000. Indications: correction of hypovolemia, prophylaxis of DVT, and post-operative and post-traumatic thromboembolism, and to improve the blood flow and microcirculation in, in threatened vascular gangrene. Side effects are acute renal failure, hypersensitivity reaction, and dextran may interfere with blood grouping and cross-matching. Contraindications: severe anuria or severe oligoanuria and renal failure, known hypersensitivity to dextran, severe CHF or circulatory overload, bleeding disorders such as thrombocytopenia, hypofibrinogenemia, etc., and severe dehydration. What are the precautions we have to take during dextran administration? Dextran should be administered with caution in patients with impaired renal function and oliguria, acute, that is active hemorrhage, chronic liver disease, and patient at a risk of development of pulmonary edema. The hematocrit should not be allowed to fall below 30. So now we are going to see some methods of delivering IV fluids. The most useful, that is routinely we deliver the IV fluids by IV set, micro drip set, and in pediatrics we'll deliver IV fluids by pediatric drip set. Methods to calculate the rate of fluid administration. The calculation of routine IV set includes rule of 10 and rule of 4. In rule of 10, the fluid calculation for every 24 hours, that is IV fluid in liter per 24 hour multiplied by 10, so we will get drop rate per minute, and drop rate per minute divided by 10, we will get IV fluid in liter per 24 hours. This is for rule of 10. And in rule of 4, fluid calculation for 1 hour, so volume in ml per hour divided by 4, so we will get drop rate in minutes, and drop rate in minute multiplied by 4, we will get IV fluid in liter per 24 hours. So this is for rule of 4. So for routine IV set, 15 drops per ml, and for micro drip set, 60 drops per ml. So drop rate calculation, volume to be infused in ml divided by volume of infusion in hours multiplied by 4, so we will get drop rate per minute. So this is all information about intravenous fluid. Thank you.